I am presenting from Medicine 4. My topic is Loop 4. Mr. J, a 67 years old gentleman from Jamshedpur, presented with the complaints of cough for 8 months, loss of weight of 10 kg over the last 6 months, fever for the past 2 months, bilateral lower limb swelling and palpable red lesions over the ankles for the past 2 months, hematuria for 2 months, fatigue for 2 months. Cough, which was insidious in onset, intermittent, no diurnal or seasonal variation, worse on lying down on left side, associated with minimal mucoid sputum, no hemoptysis. Fever, low grade, intermittent, not associated with the chills and rigors, evening rise of temperature with excessive sweating. Bilateral lower limb swelling and palpable red lesions started with pedal edema and extending to ankles, intermittent palpable red lesions over the ankles. Fatigue, which is progressive fatigue and tiredness over the past 2 months. Outside hospital, he was diagnosed with anemia and transfusion of 3 units of fat cells and FFP. And past history, no comorbidities. No history of nosebleeds, no history of loss of sensation over the extremities, no jaundice bleeding manifestation, no exertional dyspnea or syncope, no burning, obturation, loose stools, no lumps or swellings noted. Past history, no comorbidities, no past surgeries, 2 doses of COVID vaccine received. Personal history, vegetarian diet, no addictions. Examination wise, positive findings are appears pale, bilateral pitting pedal edema extending to the ankles present, palpable purpura over the lower limbs present over the ankles, both ankles, and few subcentimetric bilateral inguinal lymph nodes present. And all other system-wise examinations, no abnormality detected. So summary wise, the patient presented with a symptom complex of fever with loss of weight and appetite, hematuria and palpable purpura over the lower limbs. So the as all said, the differential diagnosis. Differentials considered were small vessel vasculitis, so ANCO-positive small vessel vasculitis and immune complex mediated with good posture, cryoglobulinic, IgA mediated hypocomplementing. In view of age and constitutional symptoms, the possibility of underlying malignancy also considered. B-cell lymphoma, solid organ malignancies, renal and hepatic. So baseline investigation showed anemia, total count of 18,100 and anemia of 6.3 and neutrophils of 85 and lymphocytes of 9 and urine routine showed hematuria 3+ blood positive and RBC 1398 positive and chest X-ray showed diffuse reticular interstitial thickening in bilateral lower zone, ECG normal, echo showed grade 1 LV diastolic dysfunction. Electrolytes apart from this, no other abnormalities in baseline investigations. So when to suspect vasculitis? So whenever patient present with unexplained systemic illness or unexplained ischemia in the absence of risk factors for atherosclerotic vascular disease, or whenever there is a multi-system disease involvement, especially in the presence of systemic inflammatory response or features such as palpable purpura, pulmonary infiltrates and microscopic hematuria, chronic inflammatory sinusitis, mononeuritis multiplex, glomerulonephritis. Our patient, he had unexplained systemic illness, palpable purpura in the lower limbs, hematuria. So we suspected systemic vasculitis in our patient. And when to suspect specific type of vasculitis. Before that, we have to know that 2012 revised CHCC nomenclature, Chapel Hill concerns, everyone must know. So large vessel, medium vessel, small vessel vasculitis, variable vessel vasculitis, and single organ vasculitis, secondary vasculitis. So when to suspect specific type of vasculitis? When our patient present with limb claudication, asymmetric blood pressure, absent pulse, Drury, aortic dilatation, we have to suspect large vessel vasculitis. When our patient present with cutaneous nodules, ulcers, livedo reticularis, digital gangrene, microaneurysms, mesenteric ischemia, we have to suspect medium vessel vasculitis. When our patient presents with palpable purpura, urticaria, hematuria, sphincter hemorrhages, uveitis, mononeuritis multiplex, we have to suspect small vessel vasculitis. Our patient, he had palpable purpura and hematuria, so we suspected small vessel vasculitis in our patient. So approach to vasculitis. So 5 questions to ask whenever we suspect vasculitis in patient. First, is this a condition that could mimic the presentation of vasculitis? And is there a secondary underlying cause? And what is the extent of vasculitis? And how do I confirm the diagnosis of vasculitis? What specific type of vasculitis is this? So first question, is this a condition that could mimic the presentation of vasculitis? Why we have to ask this question? Because treatment of vasculitis is immunosuppressive drugs. If infection not recognized, giving immunosuppressive drugs would be disastrous. So conditions could mimic vasculitis are infections, thrombotic disorders like antiphospholipid antibody syndrome, thrombotic thrombocytic purpura, sickle cell disease, embolization from atrial myxoma, and cholesterol emboli from athiroma. And non-inflammatory vessel wall disorders like fibromuscular dysplasia, amyloidosis, scurvy, and vasospasm due to ergot alkaloids. So appropriate infection screen in all patients with a suspected vasculitis, especially who present with systemic inflammatory features, it must. And second question is there a secondary underlying cause? Why we have to ask this? Because treatment is different from primary vasculitis, and also on infections, one of the secondary causes. So giving immunosuppressive therapy in undiagnosed infection also dangerous. So what are the secondary causes of vasculitis? Inflammatory disease of unknown etiology like rheumatoid vasculitis associated with the SLE, Sjogren, IBD, and sarcoidosis. Infectious diseases like hepatitis B, C, HIV, mycobacteria, and syphilis. Neoplasia, hematological malignancies such as myeloproliferative, lymphoproliferative disorders, and solid tumors. Drugs like hydralazine, propylthiouracil, montelukast. These are implicated in the ANCA-associated vasculitis. Then, investigation to consider in the initial evaluation of patients with a suspected vasculitis. So, to rule out all these questions. So, to exclude the vasculitis mimics and secondary causes. So, infection screen is must. We have to do blood culture, echocardiogram, hepatitis B and C, HIV test, procalcitonin, TB. So our patient, we did blood culture which is negative. Echocardiogram showed no vegetations. BBB negative. So TB sputum expert negative. Procalcitonin also within the normal level. So infection ruled out in our patient. Then other investigations to rule out mimics and secondary causes. So for thrombotic disorders, APLA, and for inflammatory disorders, ANA anti-GBM antibody. For neoplasia, CE, CT, thorax and abdomen. For drugs, elaborate history. Our patient, AN is negative, drugs, no history suggestive of drug intake, so ruled out. Neoplasia, screening all patients with vasculitis for malignancy would not be cost effective. So who to screen? So when vasculitis does not respond to corticosteroids or refractory treatment, and atypical clinical features such as profound weight loss and previous history of treated malignancy. In our patient, given the age and profound weight loss, we proceeded with investigations to look for an underlying malignancy. So we did CE, CT, thorax and abdomen pelvis, which showed multiple enlarged para-aortic and iliac lymph nodes. And we did ultrasound guided biopsy of the left external iliac lymph node, which is predominantly fibrocollagenous and fibroadipose tissue with a scanty lymphoid tissue. And from the basic investigations, anemia find out which was normocytic normochromic with RPF less than 2. So we proceeded with the bone marrow, which was showing partly subcortical marrow with interstitial and paratrabecular B lymphoid aggregate suggestive of low grade B non-Hodgkin lymphoma. So small vessel vasculitis in this patient is probably secondary to low grade B cell non-Hodgkin lymphoma. So according to the approach, third question we have to ask is what is the extent of vasculitis? So why we have to ask this question? And because life-threatening internal organ involvement should be identified promptly and aggressive management should be done. For example, combination therapy with the cyclophosphamide and methylprednisolone in granulomatous polyangiitis to prevent end-stage renal disease, and in giant cell arteritis need to be treated aggressively if imminent threat to sight. So how we have to find out what is the extent of vasculitis, detailed history and physical examination, chest x-ray, urine routine and microscopy, nerve conduction studies. So in our patient, detailed history and physical examination suggested involving lung, kidney and skin. Chest x-ray normal, CECT no in lung involvement, so lung involvement ruled out. Urine routine was showing hematuria, phase contrast microscopy was showing isomorphic RBC. So extent in our patient is small vessel vasculitis involving skin and kidney. And how do I confirm the diagnosis of vasculitis? Tissue diagnosis is vital to confirm the diagnosis. Site to be biopsied based on the presentation. If multi-system involvement, choice of biopsy site is based on if the treatment decision, it will alter. So we have to take that biopsy. If tissue diagnosis is impractical, large, for example, in large or medium vessel vasculitis with no accessible tissue for biopsy, we have to do angiogram. So in our patient, since skin rash is transient, no active lesions, so we could not do biopsy. So probable small vessel vasculitis in our patient. And what specific type of vasculitis is this? Why we have to, because treatment differs and prognosis also differs. So investigations to be sent to identify the specific type of vasculitis are ANCA, cryoglobulin, complement levels, eosinophil count, IgE levels, specific find, and biopsy. So in our patient, ANCA negative, cryoglobulin negative, C3, C4 normal. So probably based on the evaluation, our patient had probable small vessel vasculitis secondary to low grade B cell non-Hodgkin lymphoma. So these are the article published. Generalized B cell non-Hodgkin lymphoma in association with leukocytoclastic vasculitis and disseminated intravascular coagulation. So there is a case report: 66-year-old woman with 4-month history of weight loss, productive of dyspnea, epigastric pain. On evaluation, she was found to have B cell NHL discovered in association with leukocytic vasculitis and DAC. And so one more study. This is a 62-year-old woman presented with the palpable purpura in the palms and soles, arms and legs, malaise and non-productive of decline in mental status. And further evaluation, he was found to have a solid organ malignancy, non-small cell carcinoma of the lung. So according to this study, so what is the why vasculitis as a manifestation of cancer is not well understood. There is a hypothesis immunogenicity related to cancer antigens which may share homology to vascular antigen or alteration of self antigen in the vessel wall. And according to this study, hairy cell leukemia can manifest as a paraneoplastic vasculitis, either as a cutaneous vasculitis or pan. So cutaneous vasculitis is the most common form of vasculitis associated with cancer. So these are my references. Learning points are approach to vasculitis, nomenclature of vasculitis, and small vessel vasculitis as a paraneoplastic manifestation of underlying cancer.
Do a renal biopsy. Quantify the proteinuria. Yeah, proteinuria.
No proteinuria, only hematuria.
Yes. Protein is what is that?
No, we didn't.
UP by UCL is harder.
No.
Are we treating the lymphoma? Is it under follow-up?
No, so he is not willing for treatment here, so he went to his local place for further management.
Would the vasculitis be an indication to treat the like a low-grade lymphoma? Would the this vasculitis with the hematuria now be an indication to treat the lymphoma?
Yes, ma'am.
So what was the treatment plan? Treat vasculitis, treat lymphoma,
Yep.
treat lymphoma at that grade.
To treat lymphoma.
So what was he discharged with? What advice?
That he discharged with a slide from here biopsy, which he want to continue the further treatment in this local place.
What was our advice? You will take the treatment there, that's fine. What was our advice? What should be the line of management or treatment for this patient?
To take the underlying mail.
Sorry? Thanks.
Clarity of presentation and interesting way it was presented. I would give the prize to Dr. Sam Arun Manoj.